are you able to sleep better? Do you feel with more energy? Are you able to concentrate better? Are you able to do things that you were not able to do before? So that they feel that it's not something that they have to change in their appearance, but a healthy lifestyle that we're trying to achieve.
Welcome to another podcast, PEDGA Digest. I'm Dr. Hernández, your host today. I have the pleasure of having with us today Dr. Caren Pichardo. And we are going to be discussing today topics about obesity in kids, in pediatrics. And first, I would like to start. Hello, how are you?
Hi, Dr. Hernández. Thank you so much for having me here.
It's a pleasure. Karen, would you talk a little bit about yourself, like what you do and how do you got here?
So I was born and raised in Dominican Republic. I did medical school there. I had a passion about nutrition since I was in medical school, and I come from a family that has a lot of obesity and comorbidities due to obesity. So I always was like their nutritionist. I was in between GI and endocrinology until I trained with you during my residency at Nicholas Children's, and that's where I fell in love with GI and decided to integrate both by taking the path of doing obesity medicine. So I've been able to work really closely with endocrinology and with GI and with the nutritional aspect. And also I have a passion about psychology and behavior. So this area allows me to integrate all my areas of interest in one.
And my understanding is that during fellowship and after your fellowship, uh, you had developed some expertise also on kids with obesity and overweight, and you had the opportunity to see a group of kids in the past with this condition.
Yes, I went for training to Washington, D.C. to Children's National. There, they had a multidisciplinary clinic for intensive lifestyle intervention called the Ideal Clinic, and I had the opportunity to rotate with them during my fellowship. When I finished my training, I went to a community clinic where I had a mostly Hispanic population with an increased risk of fatty liver and obesity, and I had a group of patients that I saw every week for lifestyle interventions like cooking demonstrations. We did exercise and we spoke about all the lifestyle interventions. Plus, I had an obesity clinic and a GI clinic in this setting.
Beautiful. So let's dive into our podcast. So it's common sense that overweight or obesity are persons or human beings or kids that they weight above their standard based on age. But can you tell us a little bit more in terms of how would you define obesity in a patient?
Okay, so what we know now is that obesity is a chronic condition. It's a chronic medical condition in which once you develop it, your body will try to regain the weight continuously. So that's why the definition has changed to include it as a chronic condition, a diagnosis. So obesity in children will be defined with a BMI greater or equal to the 95th percentile for their age.
And BMI is defined
So the
as
BMI will be defined as a body mass index that will be a correlation between the height and the weight of the patient correlated to what will be the standard for their age. So if it's above the 95th percentile of what will be expected for their age, that will be defined as obesity. And pediatric overweight will be defined with a BMI between the 85th to the 95th percentile.
and so what once you see in your practice a patient who is either overweight or obese, what would be the risk factors that patient may be predisposed to being obese?
The risk factors of conditions that the patient can develop because of the obesity. So these patients are going to be at increased risk of having dyslipidemia, so increased cholesterol.
No, why patients who are obese, before we get into that topic, uh, develop obesity? What are the risk factors that they may be exposed to becoming
Okay.
obese?
Okay. So we have a genetic predisposition. So we have some genes that can predispose us to develop obesity. There's also epigenetic factors. For example, a mother that had diabetes during pregnancy, a child that was premature or had underweight when was a child. All these things can change the DNA methylation and can predispose to developing obesity in the future.
So there are genetic factors linked to obesity in humans and kids, so we can say that obesity is heritable type of conditions, or
We can say that it's multifactorial. So there is a genetic component that how I like to explain it to my patients is that that's like the light switch is there, but we need to have something else that turns things on. So we need to have a factors of the environment. The right now factors that can be involved is nutrition, the high availability of ultra processed meals, and lack of physical activity, the high use of screens. All that will be the environmental factors that will like make those genetic factors appear
so we
in
call
some
it a
of the patients.
polygenetic. So many is a group of factors that intervene and are associated with higher risk of kids to being obese.
Correct.
And so in terms of so it's usually we tend to see it more in kids with who are eating higher calories on their diet or are exposed to higher amount of calories. In terms of diet, um, there are any type of food that patients or kids are exposed that makes them more obese?
So the ultra processed meals, the sugary beverages, I think it's an important one. Juices, soda, iced tea, sports drinks, all these are high in sugar, are not going to fill them up. The sweet cereals, the snacks, the fast food, the junk food, those are foods that tend to be high calorie, are hyper palatable. So have a strong flavor that the kids are going to get very saturated with this and are not going to enjoy the healthy food as much.
So our genes or genes, human genome or human gene sequence, it hasn't changed since we are humans. So why now we are seeing more of the epidemia on abundance of kids with obesity and overweight
So
compared to the past?
there are multiple factors. One of them is the availability of food. For the first time in history, we have an excess of food. So our genes have developed trying to prevent us from losing weight and trying to keep us with a healthy weight when there's a starvation. So the beneficial genes in the past were the genes that allow you to keep your weight, to have a high caloric intake, to not get full easily, and to enjoy eating. Like we have a predisposition for enjoying foods that are high in sugar, high in energy, because of when that was available, we needed to get those. So that's how our genes develop throughout evolution. So now those genes that help us get here, now in a society that we have an excess of food, those genes are the ones that are not beneficial, because what kept you from not losing weight when the starvation came are the ones that are going to make you develop obesity when there is an increased amount of food.
So it's not that our patients are less sedentary or they're doing less sports. It's that they're overeating more compared to the past generations.
Think that there is a combination of both. Like we have all these ultra processed meals that, as I said, are very um, are not natural flavors. The ones that we throughout history have been eating, so it can create more appetite. Plus, it's more available. we have excess of food, so we are doing multiple meals a day. The kids are more sedentary. We don't have as much physical activity. The kids are seeing screens most of the day. So the combination of all these factors, I think, have triggered this
It seems like
epidemic.
technology has drive peoples of human beings to be less, I mean, more sedentary, and then excess of calories that we're exposed, plus food that are more palatable or easier of a better flavor to have, and then that increases the consumption of calories in our patient.
Correct.
Um, in terms of genetics, uh, we have learned that there are genes that they have been linked into, and it runs through families. That they makes our patient more predisposed to being overweight. The any genes that you remember that may be linked to obesity or maybe a familiar predisposition towards obesity?
So we have syndromes that are going to predispose to obesity, like it's Bardet-Biedl. We have also Alstrom syndrome. We have gene mutations on the FOT that are going to be the ones that regulate hunger. We are going to have also like disruption on the response to the hunger hormone. So we have different pathways through which our body can detect satiety or hunger. One of them is ghrelin. So it's believed that these patients that have an alteration in these genes can develop a resistant to ghrelin. So they might produce more ghrelin, which will that's the hunger hormone. It's going to give you hunger. So that can predispose to more obesity in some families. There are other patients. There is another hormone that is produced by our intestine when sorry, by our fat cells, that is the leptin, that is going to signal to satiety. So once you're full, that hormone will let your brain know that you're full. But some patients can also have a familiar form of resistance to this substance. So these patients are not going to feel satiety.
So there is a group of genes that we've been become aware of that are linked to appetite, either stimulations or decreased appetite. That those genes interact with your hormones and the hypothalamus, that it drive more appetite or less appetite, and then depends on the mutation, what it makes you more predisposed. I believe, and correct me if I'm wrong, that there are patients that even that we haven't been able to identify mutations on those genes, and even though without mutations or having anything familiar in the background, they also are predisposed to obesity.
We have not been, we don't know specifically which are the genes that are producing these mutations, but we have companies that are developing gene panels that help us determine which genetic mutation correlate with these syndromes. And there are specific medications that have been approved to treat those pathways.
Those mutations or those pathways. Now, so touching a little bit about epigenomics. So for the audience to become more familiar with these terms, so epics, it comes from I believe it's a Latin word for above or control, and genomic, it comes from genes. So we have learned for the past several years that even though the human genome or human gene sequence or sequence hasn't changed, it's still, as a human being, has continued the same blueprint. There are a group of genes with those genomes or with our genomes that can be turned on or off, and then that's activation or deactivations of those group of genes lead to formations of good proteins or bad proteins that release into inflammation, disease, cancer, so on, so on, so on, so on. So those genes being turned on or off uh, can be uh, can be done through this epigenomics, which is the chemicals that makes that those genes being activated or no. Could you comment a little bit about in terms of now knowing what is the epigenomic factors that are linked to the epigenomic that it leads into patient being more overweight, or those factors in the epigenomic that turns the genes that are leads you to eat more. So, like in terms of the epigenomic, so even before kids are born, it depends on, and I believe it also dad too. It's part of this. I mean, dad is a smoker. I think there is a certain predisposition towards a bad epigenomics towards a kid, and even obesity as well. So it depends on mom's diet during pregnancy. It leads into changes on that epigenomic turn on genes that predispose you to obesity. So it's not only kids being exposed to a healthier diet, it's also moms during pregnancy should be eating healthier as well. And then after the kids are born, or after birth, uh, what kind of diet or can influence that epigenomic?
So a diet high in ultra processed food, high in sugars.
No, but I was referring more, and I was asking that question because it's my understanding too that breastfeeding or breast milk.
Yes. So there's factors there as well. So going to the beginning in the uterus, what factors can influence? The diet of the mother. If mom develops diabetes, the high sugar, high insulin environment inside of the uterus is going to predispose that child to develop obesity in a later time. Also, a child that has had decreased energy, so it's going to have like all this the insulin will be increased. So a baby that has poor weight gain, infant with introgrowth restriction, intrauterine growth restriction, all that will predispose in a later time that that patient could develop obesity as well. So that will be intrauterine. Then when we go to the delivery, what factors predispose? There is going into the microbiome. That is another thing that could be related into developing obesity. What is the microbiome that you have? There might be a difference in between C-section babies and vaginal delivery babies. So there are a lot of studies underway, but there's no guideline that will tell us that being a C-section baby will predispose you or it will be protected to be a vaginal birth. But these are things that are being studied. So that will be when the baby is born. Early use of antibiotics in babies, in incubators, that can also change your microbiome and it can also predispose to later development of obesity. Again, there's no guideline that tells you that you should avoid the antibiotics. Like the first thing is to treat the baby, make sure they get out of the infection, so it wouldn't be a reason not to give it. Then once we go to what is that baby going to eat, and if it's going to be breast milk or if it's going to be formula, it's believed that babies that are formula fed could develop more obesity than babies that are breastfed. One of the things that might play a role in it, it will be the responsive feeding. When a baby is breastfed, the baby takes as much as needs, and after that starts doing non-nutritive suck and wouldn't take more. But when a baby is formula fed, sometimes if parents are not following hunger cues, the baby can be overfed, and that can lead to a disruption between the satiety signals in that baby since an early age
And overfeeding.
and the overfeeding. So one strategy that can be developed in that early period is to teach parents to how to know the satiety and hunger cues in the babies so that we can avoid that.
So let's switch gears a little bit about a comorbidity in obesity, or why it's important for families and our patients to be aware of not becoming obese. So what are the type of comorbidities that are linked to obesity?
High blood pressure, high cholesterol, high triglycerides, diabetes, prediabetes, insulin resistance. We can get obstructive sleep apnea, anxiety, depression, problems with bullying at school due to the obstructive sleep apnea, behavioral problems, learning difficulties. These patients can also have musculoskeletal problems, like problems with the muscles, the joints because of the high weight. So we can have a
So
sleep
they are
cap.
more prone to surgeries, to
Yes,
surgical intervention as well.
as well. They can develop sleep capital femoral epiphysis, in which, because of the height weight, they can have fractures. They can have the they can later. So if you have a child that it's over obese as a child, they are more likely to become obese as an adult. So this will be another comorbidity that will continue with them throughout their lives. Then we have the fatty liver with the potential of developing liver fibrosis, cirrhosis, liver transplantation, and liver cancer as well.
Yeah, I think it's more than liver cancer. I think in adults, more like, I mean, we don't see cancers related to obesity in kids, but they have been well described in adults that the cancer predispositions of many type of cancers when adult patients are obese. So it's a bunch of comorbidities on kids who are overweight. In terms of the management that we do in our patients who are overweight and obese. So tell us what you do in your practice. So usually we start on an exercise plans, on a dietary plans. So what do you do in the practice as an intervention for patients that are known to be obese or overweight?
So the first thing for me is to understand each patient, and I try to get into their eating habits, their lifestyle, to try to understand what are the lifestyle interventions that we need to have, because we have patients that are snackers, that they like to graze throughout the day and eat small amounts of high calorie food, but they wouldn't have a large plate of meal, or patients that do not eat vegetables, patients that drink a lot of sugary beverages throughout the day but do not have a big appetite. If it's a lack of physical activity, if it's there's a something on the environment that we can do to improve all these. In children, the best intervention that parents can achieve will be changing their environment. So if their environment contributes for them to get healthy in children, that will make them healthy. So if the availability of food that is not healthy is there, unfortunately, since they don't have development of the frontal lobe, they don't have auto control. So they wouldn't be able to control themselves knowing that the food is there. So I try to counsel the parents to try to remove those things from the house, to try to make it easier for them. Um, so we try to develop small goals each time to make it more sustainable for families, because what we can see is that families come with a lot of motivation and they're willing to make all the changes, but once they get back to the reality, to the hectic lifestyle that we have, then they realize that it's not sustainable to do everything at the same time, and they lose motivation, sometimes stop coming. So it's important to let them know that it's the healthiest step that they can take, even if it seems insignificant. Because we try to stagger all these new habits until we achieve a healthier lifestyle. And our goal is not like a JoJo effect that I lose weight, I gain weight, because that could be more damaging for the liver and for their health in general. So those are the things that I try to understand for each one. There's no specific diet that has proven to be effective for everyone. Um, so there's not like the ketogenic diet that has proven, intermittent fasting. It depends for each person. There is going to be a diet that it will work, and we need to find it as a team which one is the one that works for this family.
And in terms of an exercise plan, so encouraging patients, our patients to practice sport. So at what age you start encouraging them to exercise more or practice, to start practicing sports?
So I think that as pediatricians, we need to start recommending physical activity since they are 4 months, and we start telling them that they need to be on their belly for play. That's when we need to start the interventions. We need to start with prevention, with watching, teaching parents hunger signs, teaching what is a normal eating pattern in a baby, what are normal portions in a toddler, so that parents are reassured that they are providing enough quantities to the child and that the growth is appropriate. So that will be a way of early on to try to prevent all these. As soon as they are able to walk, then we need to start taking them to do free play, going to the park, moving, trying to decrease the amount of screens. The recommendation is for children less than 18 months, they shouldn't have any screen time. So if you are not able to have a baby on a screen, you're not able to have them sedentary. So they will be moving. After that, the recommendation is not more than 1 hour for children up to 5 years, and after that, it's 2 hours. So if you account for that, there's not a lot of time for them not to be active if we are following those guidelines. So with regards of the physical activity, I understand that right now a switch has been that not all the schools are providing physical activity as part of the curriculum, and parents have mentioned that sometimes they have they don't have it as part of the curriculum during that quarter, and the children, that will be their only exposure to exercise. And since parents arrive home late after it's already dark, they are not able to take them to other activities, or they don't have the money to pay for them. So what I try to develop is a exercise plan at home, even walking inside of the house, anything that will make them move and move continuously. So setting an alarm that every hour that they are sitting, they need to start walking, to try to develop a small habit of moving, and that sensation of achievement, that they are able to make changes, and that those changes add up and will make them.
But would you throw in any message to school systems about kids' diet and keep them active, or do you think the school system nowadays is doing a good job preventing obesity in kids?
I think that as a society, we have a lot that we can do better. Because before, we used to believe that obesity was something about self control, and it was more about personal discipline and personal responsibility. And now we understand all these different pathways that are going to make some people more predisposed to gain weight, and more difficult for them to lose weight. So, as a society, if we want to continue having healthy children, healthy adults, we need to make it easier for them to make the right choice. So, change their environment. So, the school, I think that we should have physical activity and recess as part of the curriculum. We need to show our society that moving our body is it's important.
So one, and you mentioned it, other comorbidities linked to obesity that we are seeing the crescendo or a significant amount of higher incidence is liver disease in patients who are obese or overweight. Now we are calling this MASH, or muscle D, metabolic associated liver disorders, which definitely is a strong comorbidity of patients who are overweight. They are super predisposed to get significant liver disease down the road in life, and even being exposed as an adult, early adult, into having a liver transplantation as well. So these patients, that significant amount of patients that we are seeing with liver disease, I believe there is also genetic predisposition, not only for them to be obese, but once you're obese, there are also patients who are more predisposed to have liver disease because also genetic predisposition. And I believe there are genes also that nowadays you can screen to see those patients obese. They have mutations in their gene that predispose them more to liver disease or liver fibrosis. Is that correct?
That's correct. That's underway. Those are studies, and there are ways of doing tests. And it's exciting to think that in the future we will be able to have a more precise way of detecting which patients are at increased risk, and to be more aggressive with those patients. What we know so far is that, for example, certain your ethnicity could play a role in if you are at increased risk of developing fibrosis or developing liver disease. So, for example, Hispanics, we are at increased risk of developing liver disease. Mostly, also Hispanics coming from Mexico seem to have this genetic mutation that will predispose. There are some genes that show that could be protective against developing liver disease. So I think that the more we develop these type of studies, the more we will be able to understand and to find therapies that will
Target
target
those
those.
genetic predispositions. Yeah, you're right. I believe that one of the genes that we shared before we talk about it in the past is the PNPLP3, which is more highly expressed in the in Hispanic population, which is common in South Florida. And exactly what you're saying, it's a gene that is seen more in populations from South America and also some Central America, less in the Caribbean. But if you have that type of mutation, it's not only you are predisposed to obese of being overweight, but now you are predisposed to have more liver disease after being overweight. Now let's jump in a little bit into in terms of drugs or medications that we're using right now, and then last surgical procedures of bariatric surgery that we may be indicating in patients who are overweight. So in terms of drug, now you have a patient the likely ploy is going to be more towards this family history of genetic predispositions toward being obese. And now you have tried a significant amount of physical activity. We know that family kids are conscious of keeping a clean diet or a diet that they shouldn't be that significant obese. So what is the group or the type of patient that they will be candidate to have treatment or medical treatment for obesity and overweight, and what type of medications would be your first choice if you had to jump into medications to treat obesity?
So for children that are less than 12 years, we don't have as many options. We have orlistat that is going to interfere with the absorption of fats, but it's not a medication that patients like to use because it's going to develop diarrhea. They can develop deficiencies of vitamin. They can have episodes of soiling and caprices. So it's a medication that we don't commonly prescribed, but it can help with a small amount of weight loss in children that are not at the 12-year-old mark. That will be the one for to be able to start the injectables, the GLP-1s, like Ozempic, Wegovy, or their generic name semaglutide, that is approved for above of 12 years. So for children younger than 12 years, we're a little bit limited about the medications that we can use. We can use metformin that can cause some amount of weight loss and can improve with the utilization of sugars and can prevent a little bit the um, the the consequences of being overweight. But above 12 years, since last year, it was approved the medications, the GLP-1s. So has changed completely the
So
way that we
GLP-1
process.
stands for the glucagon like peptide one.
One, correct. And then we have a different
So what this type of medications, so how they work, what
so
this type
how
of
these
medications do?
medications work? So these medications are going to work as agonists in these receptors. So they are going to work on those receptors that are going to help with the utilization of sugars, are going to help to for the cells to be able to produce insulin secondary to sugar. When sugar comes in, insulin will be released. It's going to help with satiety. So it's believed that these medications can go to these areas in the hypothalamus and help to decrease the appetite. And also are going to decrease the emptying of the stomach. So how fast the food passes from the stomach to the intestine. So the patient are going to have more a sensation of feeling full. So the appetite will go down. And then we are going to see weight loss with these medications. So this has changed a lot the way that we practice obesity medicine now in children above 12 years. These medications have also been proven to be effective for in adults for obstructive sleep apnea. So it's now indicated for that. It can help with PCOS, that I forgot that is another comorbidity of obesity, polycystic ovarian syndrome. It can help as well with liver disease as well, with even with the fibrosis in patients with MASH.
Yeah, sorry, right. And actually, I have used in the past metformin in patients with liver disease associated to overweight with good success as well. I mean, exactly what you say, it decreases the chances of insulin resistance. So they get less hungry, more full. And I believe that it blocks on the pathways of glucagon that decreases the glucose release from your liver as well. In terms of side effect, I mean, a kid or a pediatric patient or a family should be concerned for using any of these glucagon like peptide 1 as a treatment for overweight or obesity.
So what I usually counsel the patients on of the side effects is that since we are decreasing the gastric emptying, the same thing that is going to help us to feel satiated and lose weight initially can cause us to have reflux, abdominal pain, nausea, vomiting. It can cause constipation. So for that reason, we start with a very small dose of 0.25 milligrams for the first 4 weeks so that the body gets used to this, because usually as the time passes and we develop more tolerance for these symptoms. It can worsen reflux as well. So those are the initial and the most common side effects that we get with the medication. There's also an increased risk of developing cholecystitis, so inflammation of the gallbladder or of the pancreas related to the medication. So we have to be cautious that if the patients are having vomiting, abdominal pain, that we need to check for these possible adverse effects. Another thing is that it increases the risk of thyroid cancer or thyroid nodules. So in families that have MEN2A, MEN2B mutations, that are mutations that will predispose to a specific type of cancer in the thyroid that is called medullary thyroid cancer, this will be a contraindication to use the medication.
So if the patient has a family history or someone else, a close relative, with a mutation that it leads into a thyroid disorders or the thyroid cancer, those patients shouldn't be exposed. And then for the audience to understand this, so the medication, one of the way that it works, it decreases the way the stomach empties, so it makes you full, it makes you feel full, so you're not hungry anymore. And then, but that one of the side effects is also that it can lead into significant paralysis of the stomach, gastroparesis, and then triggers nausea, vomiting, and so on. So this side effect, once you have gallstones or gastroparesis, it would be an indication to stop the medicine, decrease the dose, and keep on going, or what would you do?
If it's only nausea that the patient is having, it will be to decrease to the previous dose. But if a patient has developed pancreatitis with the medication or gastroparesis, that will be a reason to stop the medication.
So moving, so as part of the treatment also, had your patients or you've been working with dietitian, being involved or consulting dietitians and psychologists in the treatment of your patients, or what would you do?
The part of the mental health is very important, so I try to check for this comorbidity. If there's any anxiety, any depression, any problems with bullying at school, any internalized bias that sometimes the children have heard so much about how they might feel that they're not good enough because of their weight, how that has started to affect their self-esteem. So this is something that I try to check a lot with the patients, and also to reassure them that we are not trying to change their appearance. This has nothing to do with appearance, and I try to not pay as much attention to the weight or talking about weight, and more paying attention about health. And I try to make it a point for them to be paying attention what are the non-scale related successes that they have had. Like, are you able to sleep better? Do you feel with more energy? Are you able to concentrate better? Are you able to do things that you were not able to do before? So that they feel that it's not something that they have to change in their appearance, but a healthy lifestyle that we're trying to achieve. So since I'm going so much into the aspect of the mental health, I tend to refer a lot of my patients for psychology. Also, since we are implementing lifestyle changes, these are behavioral interventions. So my visits with the patients are more of them telling me what they want to do, what they feel that they need to do or were not able to achieve in the last month. I analyze why they feel they were not able to do it. So there's a process that it's called um,
Is it psychological intervention or?
so the way that we are supposed to ask the questions for the patients,
Uh-huh.
we have to ask the patient for them to be the ones putting the goal. We are there only to ask and to guide.
I see. So you're kind of pushing them to develop their own path.
Yes.
And then last on the talk today, what would be your patients that then you believe that they are candidates for a surgical intervention for obesity? And the type of surgeries that usually are recommended for them.
So children that, for me, it will be patients that are not candidate to receive the GLP-1s or that have failed on losing weight with the GLP-1s. Before, since we didn't have this class of medication, we were referring more patients for bariatric surgery, but we are now trying first to do interventions with these injectable medications.
Do they have an age specific to be a
So
candidate?
before, it was after 16 years. The new guideline that came out last year, it's above 13 because the risk to develop comorbidity is so big that we don't want to wait for them to be older to do the surgery. So now if they have severe comorbidities, they are not candidates for GLP-1s or they have failed them, we go straight to
And what type of surgical intervention would you?
gastric sleeve is the one that we do the most commonly. And then the other one will be the Roux-en-Y. We don't do it as commonly since it's more aggressive. It's going to require more vitamins and supplements after the surgery. That's why it's not usually the first step that we take with our patients.
And then after they go through a successful surgery, would you keep on monitoring those patients, or is the surgeons monitoring those patients for like a malnutrition, vitamin deficiency, or complications of the surgery? Who follow these patients after the surgery?
Usually, these patients are followed by the team of the surgical team, but I think that obesity specialists at GI, we should be involved as well. Checking the comorbidities about having the gastric sleeve, since it's going to predispose to delayed gastric emptying, to reflux, malnutrition. I think it should be a multidisciplinary approach. Also, we have to make sure, since obesity is a chronic condition, we are diminishing the amount of the stomach. We are diminishing the amount of these substances that are released that are going to increase our appetite. But we're not fixing a lot of other things, like the lack of mindful eating. There are so many other lifestyle interventions that need to take place to prevent a patient to regaining the weight. So I think that being followed by an obesity specialist and having these lifestyle interventions after the surgery, I think it's valuable.
Well, I think we have covered a lot. So thank you very much. And I mean, that was a nice discussion that we had and a nice presentation. So we're here to help our community, and I mean, hopefully to make them more aware of these type of conditions and conditions that often are preventable as well. So thank you.
Thank you so much for having me.
You're very welcome.